The White Dress Project presents Dialogue with Doctors. The topic tonight is hard questions. What are my treatment options and what do I do next? I've always found when it comes to any women's health issue, there really is a beginning, a middle, and an end. The beginning is a diagnosis. The middle is seeking out the best doctor and the treatment plan for your quality of life. And the end, of course, is recovery and continued monitoring. So tonight we have some amazing doctors here with us, and we may be having a patient advocate come online here shortly. I want to introduce you to them. The first doctor I want to introduce you to is Dr. Kameelah Phillips. She is based out of Manhattan, New York, and she is a board-certified OBGYN, a wife, a mother, and a lifelong women's health advocate. Now, since high school, she has been involved in local, national, and international organizations aimed at advancing women's health care issues through advocacy and through direct patient care. Now, she loves getting to know women and helping them feel comfortable with their bodies so they can be aware of changes or new developments. That is obviously key when it comes to discovering fibroids or PCOS or endometriosis. So Dr. Kameelah Phillips, thank you so much for joining us tonight.
Thank you for having me.
Of course. Okay, next up is Dr. Natalya Danilyants, or Dr. D as we've called her because I'm having a hard time pronouncing that last name. She's based out of Rockville, Maryland. That's kind of our neck of the woods here. Now she's also a board certified gynecologist, and she, along with her colleagues, developed the dual port GYN and LAAM advanced gynecological surgical techniques used to treat complex gynecological conditions such as endometriosis and fibroids. Now, she has received numerous awards for her exceptional surgical skill and care. She is a specialist in the treatment of benign conditions like fibroids, ovarian masses, and endometriosis. So, Dr. D, thank you so much for being here and being willing to share your expertise with us tonight.
Thank you so much for having me. I'm really honored to be part of this.
Awesome. Okay, Dr. William Nim is here. He's also based in Maryland and is a board certified vascular and interventional radiologist specializing in women's health. Now, his mission includes increasing fibroid awareness and providing education to patients regarding their potential treatment options so they can make truly informed decisions for their own well-being. That is crucial. And he also encourages more conversation about uterine fibroids in hopes that more women recognize these symptoms of uterine fibroids so they may sooner seek help and get the care they need to feel better. Dr. Nim, I feel like you really kind of embody the whole mission of the White Dress Project. So thank you for being here tonight.
Thank you for having me. I'm super excited to be here and participate in the dialogue with everyone else.
Awesome. Okay, so just in case she does pop up, or she has and we haven't seen her yet, Jae Nash is the patient advocate that we've invited here tonight. She's a radio personality for Atlanta's V103, the People Station. She has created the Girl Power Hour radio that's syndicated. So we're expecting her to come on here shortly, but as you know, everyone gets busy and things may arise and she may or may not join us. So I just want to give everyone a heads up. If you go to the bottom of your Zoom screen, there is an option to hit chat. When you hit that, a screen pops up just to the right of your Zoom screen. And in it right now are some directions for tonight. I see most of you have already muted yourself, but if you can mute yourself so that we can hear the speaker when they talk, that would be great. Feel free to drop questions in that chat at any point. I'll try to get to them when it works in the conversation. I won't get to all of the questions, and if your questions are too personalized, if you're asking for a diagnosis, you might not get one. So just to give you a heads up there. You can also see our social media handles on Instagram at We Can Wear White, same with on Twitter, and we have our Facebook link. So let's go ahead and get started right now. As I said, I feel like this whole process of dealing with fibroids and other women's health issues really is kind of a three-part story. Beginning, diagnosis, and then staying on top of your annual. So I want to start there with the doctors, and you can jump in as you see fit. But in terms of a diagnosis, when do you find patients come to see you? Is this something that's discovered when they have a major problem, when it's really affected their quality of life? Or do you find that patients stay on top of their annuals and it's something that you're able to discover as you see them yearly or every other year?
I'll unmute myself and I'll take that first. I find that a majority of my patients tend to be in their 30s and 40s when they start to deal with fibroids. And that's primarily because most of us around that time start to be reproductive, and they're wondering, why am I having difficulty getting pregnant? Or, I'm not as skinny as I was in my 20s, and they're paying more attention to their abdomen. And along with them, trying to get pregnant, they finally get an ultrasound. And on that ultrasound, it reveals fibroids. And this is something that they've never knew they had, never heard of. And that tends to be the beginning of the journey for most of my patients, early 30s to 40s.
I can add to that. Because our practice is specialized, and so we specialize in treatment of fibroids and endometriosis, a lot of women I see already have a problem. So when they come to me, a lot of them already have a diagnosis of maybe not endometriosis, but fibroids for sure, because they've had imaging. But a lot of times we see huge delay in care, whether it's because they haven't had, any follow-up, any routine follow-up, or maybe they have, but even despite their symptoms of bleeding or pain, their doctor didn't think that an ultrasound is the right thing to do. So sometimes they come in really not knowing what's going on. They know they have a problem, but they haven't had the correct diagnosis. So, obviously, as Dr. Phillips noted, ultrasound would be the next step in diagnosing and kind of identifying what the problem is. But with things like endometriosis, sometimes ultrasound is absolutely normal, right? And so it is our job to still believe the patient and understand that, pain is abnormal. And really there must be something going on. And that's when the next step of laparoscopy, which is also part of the diagnosis when it comes to endometriosis, takes place, and treatment at the same time.
Yeah, Dr. Phillips, you kind of hit on something there. You said that you get patients in the reproductive age range when they're trying to decide to start a family. And I can say personally, that's exactly when I found out that I had fibroids. Trying to start a family, went to my annual. I did notice that I was getting a bit rounder around the midsection, but I thought I've hit 30, my metabolism slowed down, and just putting on weight. Everybody does it. And my doctor took one look at me and said, nope, that's an enlarged uterus. And that was it.
Right. I think there's a few things that Dr. D and you both touch upon, and it's one, your annual. It's important. We're moving sort of away from coming in every year per se, but I still think it's actually a really important hallmark for women, because at your annual, you're getting your weight checked. And so you'll see if there's incremental weight gain, but we're also getting to know your body. We're touching you, we're examining you. And we notice these slight changes when we refer back to our notes. And so I think going to the annual is important, and not always assuming that this is just love weight and relationship weight and that kind of thing. If your pants are getting tighter, if your bleeding is heavier, we don't want to just chalk that up to age, because really we're talking about your reproductive potential.
Dr. Nim, I see you unmuted yourself, and as someone who really advocates for patient education, do you find that by the time you are working with patients, they really had never heard of these problems before?
Yes, similar to like Dr. D, most of my patients are coming once they have a problem. A lot of the doctors in this, or patients in this area, they're not just getting their women's health care from gynecologists, they're getting from family medicine, internal medicine. And so part of my practice has just been kind of communicating with those doctors, as well as, we're trying to be a team. You're working with your gynecologist, working with your interventional radiologists who are interested in helping patients with fibroids, and letting them know the different options, and working together to find the best treatment option. Either it's starting with medications or going to surgical treatment options, or non-surgical treatment options.
So we will get to those treatment options here shortly, but I see Jae Nash has popped in on my screen. So Jae, if you don't mind kind of sharing your experience with women's health and doctors and your diagnosis, if you could share that with us, that would be great.
Yeah,
And
sure.
welcome to the chat.
Yeah, hi everyone. Thanks for having me. So for me, I was misdiagnosed early on. I want to say I was in my mid 20s and it was just the hormonal imbalance and I was bleeding irregularly and all of a sudden it was like, hey, we're going to just throw you on birth control, right? That's just to regulate you. We're going to, my OB at the time was like, hey, we're just going to give you some birth control, see if we can regulate your cycle. And it helped over the years. I think I've been on just about Depo, the pills, the Mirena, just all different form of hormonal therapy. And it wasn't until just last year that my doctor was saying, there is something going on. And I was more like inquisitive about what was happening with my body because it was just changing. It wasn't just necessarily the midsection area, but it was just, I felt like I was just out of whack, like I didn't know what was happening. And I want to say that I was going to the doctor last year, maybe twice a week because I was just bleeding like really bad. I would be at an event and unexpected bleeding and it was heavy, where it just within a matter of, I want to say 20 minutes or so, I just go through like a pad and it was horrible. And she did I want to say it was a sonogram, an ultrasound. And that's when she found out that not only was it a endometrial polyp, but there was a fibroid that was both about the size of a lemon that was in my uterine lining that was causing the bleeding. But mind you, I had been misdiagnosed for so long with, the hormonal therapy. And, I'm really grateful because I'm 38 now that we were able to find out what was going on. I mean, although it took some time, now I'm at the point where we've exhausted pretty much all of our options. And I had a polyectomy and also had the fibroid removed at the top of January. And I'm still having bleeding issues, the symptoms are still there. So I am now going to have a hysterectomy 2021, January. And it was just about trying to finance it, make sure that I was able to actually afford to get the hysterectomy. If you don't have insurance, I was quoted $50,000 without insurance for a hysterectomy. It was for the robotic surgery, and with my insurance paying 60%, I still have to come up with the remaining portion. So it's just saving for that. But all of the money that I spent trying to, really just find out what was going on with me, I, just was exhausted. So it's just really good to be on here with the doctors and the other women who probably have suffered or going through something similar to what I was going through. Like I said, the irregular bleeding, the heavy bleeding, the pelvic pain, just so many different things I was just going through.
Can I just make a comment? Thank you so much, because you touched upon such huge, important issues. Number one is that it took that long in your journey to get an ultrasound, which is really, I feel so strongly about those things. As a Black woman, that should have been the first thing that you should have received, as an ultrasound. And really, pelvic exams and during even well woman exams are very limited. Whether, especially, and you look great, and I can't see you from the waist down, but larger women, especially harder, right? So if you have a fibroid, you're not going to identify it on a pelvic exam. So ultrasounds are so important, especially for women at high risk. Second thing, I mean, $50,000 for surgery, that is ridiculous. And I hope that you're, looking for a better option while you're waiting for your surgery, because you should not have to pay that much money to have surgery.
Yeah, honestly, I've tried to go the holistic route for quite some time before even the first surgery to have the fibroid and the polyp removed. And, that was an additional expense. But like I said, I just was quoted. I had the codes. My doctor gave me the codes, and $50,000, in fact, $53,000 for a hysterectomy. And then, they can't really give you what she told me, the actual price, because you may, you may have to stay overnight more, it's just so many different things that you have to factor into, getting this hysterectomy. And so, I have a 14-year-old. I'm grateful that I do have a child, but I feel like, and my doctor, she really, I have to give it to my doctor, Dr. Yo-Yo, because within the last few months, I was going to her for years, but another doctor had inserted the Mirena. So once I got the Mirena removed is when the problems really started coming about. And so, she didn't really want to just say, hey, jump in, let's just give you a hysterectomy. She really wanted to exhaust every option that was available to me before I had made the decision to get the hysterectomy. But it's very expensive. And like I said, I'm just really exhausted. I've spent so much money just trying to figure out what's happening, what's going on, and what I could do. And then too, now that my daughter is 14, it's, making sure that the situation that I've gone through, what I've had to endure, I don't want her to have to go through that in her childbearing years.
Yeah.
Absolutely. And Jae, you touch on something. Well, you all have touched on a lot that we have to get to, and I've got questions rolling in. But Jae, you touched on something like sharing this story with your daughter, because I had fibroids removed, and I remember going into surgery. My mom was like, well, I had fibroids too. Okay, could have told me that. It's like not anything that we talk about ever. So, okay. A lot to get to. First, let's talk about treatment, because those are the questions that I am getting right now. I want to tackle the holistic route that Jae mentioned, diet, because we get a lot of questions about, can I change my diet to shrink my fibroids or address my women's health issues, and fertility. Which options are available to preserve your fertility? So let's start with, the basics, the birth control, because that's another one that's, prescribed quite often. So let's start small and then work into the less invasive, more invasive, and then, the big surgeries.
I mean, birth control pills are not treatment for fibroids. It might be a treatment for abnormal bleeding, but, remember, and that's kind of where, again, my frustration is that you can treat the symptoms, but you're not really treating the condition, right? So if somebody's having abnormal bleeding and you keep giving them birth control pills, maybe they might control it for a while, but the fibroids are going to continue to get bigger and bigger. And if we're talking about fertility, the earlier you address the problem, the better the outcome is, right, of preserving that fertility. If you let this uterus grow to, enormous, like Dr. Phillips was talking about, watermelon size, right, with these giant fibroids, and now we're talking about preserving fertility, we should have done something earlier, right? So that's, obviously I'm biased because I do surgery, but also, I see very, very advanced cases. I'm not talking about little tiny fibroids, right, that are not really causing the issues. I'm talking about huge fibroids that were mismanaged for many, many years. And, these poor patients are suffering and they're losing their fertility. And some of them have never had a chance to have kids. And it's just terrible. And it really breaks my heart. I think it's wrong.
So Dr. D, talk about your specialized surgery as well.
Yeah, so we do minimally invasive surgery, for fibroid removal, that for women who desire to preserve fertility, using small incisions. It's different from just doing like laparoscopic or robotic myomectomy, because those are limited depending on the number of fibroids and the location. The procedure we do, the LAMP procedure, it's kind of a hybrid combination between laparoscopic and open. So essentially it's a very small open incision, and it allows us to remove these different types of fibroids and different size fibroids, but still keeping the incision very small, 2 inches at the bikini line. And the patient goes home the same day, and recovery is only 2 weeks rather than, with traditional 6 to 8 week recovery. But again, you're not limited as to where the fibroids are, how many or how big. So it's a really, powerful procedure, and it gives women options. And then for those, of course, that do not want to preserve fertility, laparoscopic hysterectomy, so minimally invasive, again, outpatient. And it's much less costly, right, than doing robotic, or inpatient surgery, especially for those patients that you may need to pay out of pocket. And so again, it's just a great option for patients.
Can I just say something really quick? Well, might not be too quick, but I want to be very clear that we are very clear that there's not one exact right path for everyone with fibroids. And that's why it's really important that you find a doctor that you trust and can engage in this conversation with. There's no one size fits all, and lifestyle is a big thing. I just wanted to touch very quickly, because people come in and they are saying they want to do this more holistic type of management. And in my experience, that involves like eliminating milk products, eliminating phytoestrogens in their diet, working out, meats, that kind of thing, because as we know, we have a lot of preservatives and unhealthy things in our diet. That works for some women. I want women to be realistic though with their expectations, and sometimes they have to have multiple modalities to get to the end goal, which is whatever that might be: stopping bleeding, preserving the uterus, avoiding hysterectomy. So it's important that we do this from sort of a multidisciplinary approach and not demonize any one thing. I have people who come in for fibroids and they're not appropriate surgical candidates at that time, but somewhere along their path, birth control, for example, has been presented to them in a negative light. And there's a strong role for, again, as Dr. D was saying, not treating the fibroids necessarily, but treating the symptoms of the fibroids that will allow the patient to still go to work, be functional, not have significant anemia, painful periods where she's on the bathroom floor because she can't function. So there is a hormonal role, recognizing that there's a range of hormones, right? There's pills, there's patches, there's rings, there's the Depo, there's Mirena. Not everything is going to work for you. And so this is a journey. You have to do it with someone you trust and be open-minded to what those options are. And just understand that your process is not going to be, for example, like your girlfriend's process, who might need to go straight to Dr. D and have some surgery. Just be open-minded to what it is that's best for you as an individual.
Yeah, I just
Dr. Nim, go ahead.
Yeah, I just want to say, medicine, not all patients are the same. That's why I call it the art of medicine. Everyone's a little bit different. Everyone's situation is a little bit different, and you kind of have to taking the fact of everything that's going on. One thing I did want to mention is, I understand a lot of patients get screening ultrasounds, and it's a great tool to see what's going on. But I'm curious, Dr. D and Dr. Phillips, your take for MRIs, because all my patients, we get MRIs because a lot of times, these patients who I see had ultrasounds, and they're told, oh, their doctor says we only have a few fibroids, but by the time we get the MRI, is actually the ultrasound underestimates what's going on. And it kind of makes more sense why these patients have these severe bleeding or severe cramping, and their either family medicine doctor or whatever says, oh, you only have these couple small fibroids. It's mostly, maybe it's not your fibroids, and just put you on birth control.
Yeah, I do want to touch on that real quickly, Dr. Nim, because that's exactly what happened to me. I had an ultrasound that showed 3 fibroids. And then the doctor who was doing my surgery, my myomectomy, she sent me to get an MRI. The MRI showed 6. And then when she actually did the surgery, and I had an open myomectomy, she took out 10.
10.
So I know exactly,
yeah.
I know exactly what you mean in terms of the ultrasound is just like, okay, yes, they're there, but you have to do a deeper dive to really get a better look. So I'll let Dr. D and Dr. Phillips take it away from here.
Yeah, no, I agree exactly with what you're saying. I do use screening ultrasounds very frequently. So I don't want you to think that you got shortchanged by starting with an ultrasound. Most of the time, insurances, in my experience, require you to have an ultrasound that shows a finding before you can just jump to an MRI. They just won't hear it otherwise. So I do always start with the screening ultrasound, and then I use that ultrasound that shows the finding to fight for the MRI. Certainly before you have surgery, I do recommend that you have an MRI. so that the surgeon has a better idea of what's going on. It can show us evidence of endometriosis. Yes, it is a surgical diagnosis for endometriosis, but it can show scarring. It can pick up things on the ovaries that the ultrasound may have not picked up. And I tell patients all the time to also manage your expectations with our imaging. Our imaging is limited. It's very, very helpful, but limited. And without fail, your 3 fibroids will turn into 6, will turn into 10. So that's a very common progression of this process, that we think we're starting with one thing, but we end up with something slightly different.
Yeah, I definitely agree. I'm glad, you both mentioned that ultrasounds are limited. It kind of gives us an idea in terms of kind of starting point, right? Because if there's abnormal bleeding and the fibroids are small or maybe no fibroids at all, instead of saying, oh, yeah, there's nothing wrong, everything is fine, especially in those situations, I get an MRI to look for adenomyosis, right? Endometriosis of the uterine muscle, because then the management is going to be very different. I may not say that, well, myomectomy is the right thing to do, because if you have a lot of endometriosis in the uterine muscle, then it's going to be removal of the uterus. That's going to be a better choice. So absolutely, MRIs are, a lot of time very appropriate next step.
So I do want to get to some questions right now because we have several kind of rolling in. The first woman says, I'm 53 years old, good health except for her fibroid. Ultrasound showed that it's 17 centimeters and the doctor suggested a hysterectomy because it's covering her ovaries. She wants to know if there are any other options available. And she says that she's never had any pain, symptoms, premenstrual cramps since she began her cycle at age 11. So it doesn't sound like it's really affecting her quality of life. But I guess she's concerned that maybe this hysterectomy is her only option.
You want me to go? I mean, I, as a physician, will always admit to my patients my bias in terms of my experience. And I do that because everyone comes with some type of bias, and I'll say, this is my bias, why I think you should do this, what's right for you. And we have that discussion and we go back and forth. So my bias would be that at 53, you have a 17 centimeter mass inside your uterus. Often people, for something to get this big, it's been just such a slow process that you don't even maybe know what it's like to feel normal anymore. So when you literally, a baby's head is 10 centimeters. So we're talking 17. Just to put it in some type of perspective. And so I think sometimes when patients are so used to being uncomfortable or so used to bleeding, having pain, they don't even know what real life is like, what it could be, how she could be riding bikes without comfort, running without comfort, having intercourse without sorry, I'm saying that wrong, without discomfort. So I do not think that having a hysterectomy is an unreasonable suggestion at all. I think it's actually quite appropriate at 53. I'll leave it there, but I think that maybe you really should consider how good your life, your quality of life may be if you don't have a mass that big inside of your belly. I would think about that seriously.
I love your answer because you're so animated. I think you said exactly what I was thinking. A lot of patients, when they think of symptoms, maybe their kind of typical symptom is abnormal bleeding. Pretty much everyone will, agree that heavy bleeding, what abnormal bleeding is. But other things like maybe frequent urination, sometimes, patients don't realize that that's part of a fibroid or a large mass, or lower back pain or pelvic pressure, or like you mentioned, discomfort during sex, or maybe fullness, right? Maybe they don't feel like they're gained weight, but, some buttons are too tight. Something is going on. So it doesn't have to be a blood transfusion ending up in the ER every month, but it can be these subtle things. And like Dr. Phillips mentioned, this mass has been growing for so long, so you get used to all these symptoms, and you forget, like what you said, you forget what it feels like to feel normal. Because a lot of patients, once they have the hysterectomy, they're like, oh my God, I didn't realize like that I really shouldn't be going to the bathroom every hour, that I can actually hold it for a few hours. I mean, all these little things, it's like your quality of life, you don't realize what a normal quality of life is until you get it back. So I think, yeah, at 53, it's definitely, I would say, I second the hysterectomy for sure.
Yeah, I mean, not in this case where it's 17 centimeters, but you know, I see patients who have fibroids and they get sent, but you know, I think the one thing is, you know, I don't treat a patient just because you have an ultrasound or MRI that shows fibroids, but if you truly don't have any symptoms, there's no reason to treat it. And you know, but 17 centimeters, you know, maybe truly she doesn't have symptoms, but who knows? You know, it really depends on her quality of life, like you guys were mentioning.
Jay, I think that I saw your hand was up. Did you want to jump in here?
Yeah, I have a question for the physicians. So, is it adenomyosis? I was told that we typically wouldn't, like she couldn't test for that until, I guess, after the procedure. I think it was a hysterectomy, I can't recall. But what I wanted to ask as well is, I guess it's, why is it that some people, some women, because Dr. Phillip made a really great point that everybody's situation is different. And that's something that I am grateful for my my physician telling me about. But I was just so frustrated with the process and, you know, the amount of money it cost, right? To get through to all of, like, yeah, I had to go through several different procedures, several different birth control methods, several different ultrasound, sonograms, things like that. And what she found that she was able to remove during surgery, she was like, there's a lot more fibroids in the wall, right? In my uterine wall, uterine lining. And she said, what we don't do is, if they don't bother you, we don't bother them, right? So I'm just curious because I thought maybe like, why not? You know, there were a lot of questions, and I was posing those questions because I don't know, you know, I'm just like I said, I'm exhausted. I don't know what I'm supposed to do, but it's like, well, if we were already under and I was having surgery already, why weren't we able to remove some of those as well? And she was saying that, you know, a certain amount of time you're being under, things like that. So it's just, what is the correct way? You know, what is the process? What is it really supposed to be like? And I'm sorry for being so candid about it, but, you know, transparent. I just want to know why it took so long, and, you know, why we couldn't just eliminate what we needed to do when I was already under, after having to pay, you know, nearly $5,000 for the first surgery. It's like, okay, well, we have them there, so why won't we just remove them all?
Yeah, I mean, as far as the question about the MRI, the adenomyosis, I mean, in most cases, MRI does identify adenomyosis. So I'm not sure why that wasn't, you know, presented to you and really recommended in your case, especially if you're saying, you know, you had abnormal bleeding, you really had kind of small fibroid and polyp, and the bleeding didn't resolve after the removal. So it's kind of persistent issue despite treatment of what you thought was the problem, right? So, and then why did it take so long? I mean, unfortunately, you know, your story is so typical as this kind of prolonged treatment, right? Had you maybe had the MRI earlier in the process and found the adenomyosis, and that's probably what you have at this point. I mean, that's what it sounds like. You wouldn't have had to go through all those different treatment modalities unless you chose to do it. Like Dr. Phillips mentioned before, you know, there are different options for everybody. You know, for some people, birth control pills might be a good option if it's effective and if that's what they want to do, but it's important to discuss all these different things, right? And have the patient make an educated decision rather than saying, well, let's try this, and let's try this, and let's try this, and you just keep going step by step by step, and you're spending, you know, thousands of dollars. But you're right. I mean, if it's something, if the fibroids were in a place where they could have been causing the issue, they should have been removed at the time of your, you know, hysteroscopic polyp removal, because that's what you were there for, to remove the issue that was causing the bleeding. So I'm sorry that your journey has been so long and ridiculous. Yeah.
I hope you guys can see this, and this was my anniversary card, so don't tell my husband I'm drawing the uterus on the card, but I had to show everyone this. So I wish we understood just a little bit more about our anatomy, and to your point, Jay, why sometimes multiple procedures are necessary depending on what our end goal is, okay?
Okay.
So this is my rough draw of a uterus, vagina, wait, can you see if I go like that? Vagina. This is probably where your fibroids were, inside the lining of the uterus. These cause, you know, heavy bleeding. If you're trying to get pregnant, if you're doing fertility treatments, this is the cavity of the uterus, I'm going backwards, that we want to be just pristine. And so if you were having symptoms there, if you were trying to transplant an embryo there, it makes sense to me that your doctor would only address this and leave the fibroid that was in the wall of your uterus there. You can get pregnant with fibroids inside the wall of your uterus. Sometimes fibroids inside the wall, not for everyone, but sometimes you can not have significant symptoms depending on small fibroids that are inside the lining of your uterus. It is also a different approach. This is vaginal. This other one might be abdominal. Certainly if you have fibroids on the outer side of the uterus, which can cause the pressure symptoms Dr. D was talking about, also bleeding, the bloating, the reshaping of your stomach. This is an abdominal approach. And so, yes, sometimes we try and do as much as we can, but depending on what your main symptoms are and what your end goal is, it is sometimes appropriate to do one surgery, okay, circle back and maybe have to do a second.
Wish I could drop, I have the actual, the ultrasounds. I was trying to drop them in for the file, but like Andrea made a really good point that when we went in, it was the polyp. Once I got through with the surgery, there was a fibroid about the same size directly behind the polyp that I was able to get out, and so she was trying to be transparent, but like I said, I just was kind of confused as to why the prolonging of the process when we're down. Let's just take them all. But I do understand what you're saying in terms of if it's not bothering you, and then,
Well, no, I mean, yes, it could have been addressed. That's a discussion that patients have to have with their physicians. And, if you go in for a vaginal thing and that's what you thought you were having, and then all of a sudden you have incisions on your belly and you didn't expect that, that's not good either, right? Yeah. So it really has to be a back and forth and understanding of what the end goals are and a close relationship and communication with your physician.
Yeah, I would agree with you, Dr. Phillips, because in my situation, my doctor and I became friends. I still talk to her. I had surgery in New Orleans. I live in DC right now, and we're still in communication, but our end goal was preserving my fertility. Mm-hmm. And so, like I said, the ultrasound showed 3, the MRI showed 6. When she went in there, I woke up after surgery and she said, I pulled your uterus out. I felt for every little thing, and I took everything that there was, because again, I want to have a baby. I'm looking to have a baby. So she knew kind of what the end game was. I do want to get through some of these questions quickly before we run out of time. Adrian is asking, at what point or at what size do you believe surgery should be an option as opposed to hormonal therapy or waiting it out?
I think it's going to depend on really the location of the fibroids, as Dr. Phillips drew different pictures. So if you have a fibroid that's small, but it's in the uterine cavity, that's causing heavy bleeding, that's going to be, you're going to have surgery to remove that fibroid for reasons for fertility, right? Because as Dr. Phillips mentioned, if you're trying to get pregnant, you really need that space, that cavity to be clear of fibroids and polyps, as opposed to maybe that same size fibroid, but on the outside of the uterus may not be an issue at all. So like a 2 centimeter fibroid on the outside, non-issue, right? 2 centimeter fibroid in the uterine cavity is an issue and needs to be removed. So it really depends on location, symptoms. Yeah.
And quality of life.
Right.
Next question. Monica says that she had a myomectomy back in 2017 to remove 9 fibroids. Found out this past June that 6 new fibroids have grown. Is this normal? She has not been able to conceive. Should she try to get those removed or should she wait? I can say, Monica, I had 10 fibroids removed. When I was pregnant with my daughter, they found a new fibroid. So as far as I know, because we really don't know what causes fibroids or how you get them, there's really no way to stop them or prevent them. So my understanding is, yeah, they can always grow.
Yeah, and also, you know, important to realize that fertility is such a complex issue, right? There's so many causes that, yes, it's very helpful to remove the fibroids, but what else is going on that may be causing the infertility, right? Could there be endometriosis or adenomyosis? You know, are the fallopian tubes open, right? What's the age of the patient? So there's so many other things that's important to get that evaluated as soon as possible, because like you said, fibroids come back and now you're dealing again with the fibroids. So yeah, it's very important to have the right diagnosis of infertility, what's causing it.
Yeah. Monica, I think at 39, you should already be seeing a fertility specialist. I wouldn't keep focusing on let me take that back. Yes, focus on the fibroids. These tiny fibroids at 39 might not be the issue. I think you should see a fertility specialist.
And I can say I went to one doctor for my annual, and that's when she saw an enlarged uterus. I had the ultrasound. Her advice to me was just to wait. My mom is a doctor. She said, no, go see a fertility specialist because you're looking to get pregnant. That specialist was like, what are we waiting for? Fibroids don't typically shrink significantly. It's only going to get bigger. So she recommended the surgeon who did her myomectomy. And so I saw her, and I think I was diagnosed in May, and I'm pretty sure I had my surgery in October. And that was just getting insurance lined up, and Jay, as you know, getting payments lined up and figuring out the financials of all of it. So next question is, we're mentioning a lot about fibroids and or endometriosis. This person has fibroids and I know I'm going to butcher this, adenomyosis. I try. Are the treatments applicable to both fibroids and the other situation? Are they the same type of treatments for both?
I mean, it depends on what the end goal is. I think if fertility is not on the table, then certainly you can do a hysterectomy, right? Or a partial hysterectomy for fibroids and adenomyosis, right? That's an appropriate treatment. But if we're talking about, you know, someone with extensive adenomyosis who wants to preserve fertility, you know, fibroid removal may not change their very low chance of getting pregnant, because adenomyosis can definitely impact fertility greatly. So it's, you know, again, really informing the patient what's going on and what really, you know, what is the chance of the fertility.
Mm-hmm. Next question is, I have several fibroids outside the uterus dealing with pressure, so it's affecting quality of life, also potentially affecting sexual intercourse, which is something that a lot of people don't typically talk about. But my doctor says that a myomectomy is the best way to remove those fibroids and keep fertility intact. She wants to know if there's any more less invasive options. She says her sizes are like 6, 4, and 3.
Yeah, I mean, if we're talking about if the doctor said that open myomectomy is the only option, then definitely, you know, a less invasive myomectomy is also an option. So it's still surgery and it's still removing fibroids, but not using large incisions and outpatient surgery, quicker recovery.
Yeah.
You know, I'll let Dr. Phillips and Dr. Nim cover the other, you know, options, embolization, things like that.
Yeah.
Yeah, I was just going to say, as it relates to, I know we're talking about surgery a lot, and a lot of the people I am assuming are on the call are young, healthy women, again, still in our reproductive journey. I was telling Inkim this earlier, is there are times on this journey where we have to really challenge ourselves to be brave. You know, no one is signing up to have surgery. Certainly no one is signing up to have surgery. Put your hands and your life in the hands of who you don't know to undergo this procedure that, you know, couldn't cause all the scary things we tell you, pain, bleeding, infection. It's terrifying when we tell you these things. But I encourage people to really take in the information that they're receiving and recognize that sometimes in this journey we have to be brave and we need to have surgery so that we can live our best lives, preserve our quality of life, preserve our fertility. And I think also in our community too, there is a bit of a stigma around having to need surgery or having hysterectomies. Yes, for a 23-year-old, Jay, you didn't see it. I typed you in the DM, like, call me about your hysterectomy, but like, it seems like it's not natural sometimes in our journey to have to take these drastic measures. But I would really just encourage us to be brave in making these decisions, do your due diligence with your doctors, and realize that sometimes surgery is indicated so that you can live your best life, preserve your fertility, and grow your family the way you want to.
Dr. Nim, I think you had unmuted yourself.
Yeah, you know, a lot of these questions are with fertility, and you know, I do uterine artery embolization, which is a non-surgical method to treat fibroids. You know, that's a question I get a lot from patients: is how does it affect my fertility compared to myomectomy? And I think that's always a big conversation that I have with the patients. You know, I tell most patients, you know, myomectomy is, I believe, just kind of the gold standard at first, but you know, if there's certain reasons why you can't get myomectomy, you know, uterine artery embolization is a good option. You know, the data just isn't exactly there. Even the early data comparing myomectomy and uterine artery embolization about fertility rates, you know, it's still kind of weak data. But end of the day, you know, I see plenty of patients who've seen their gyne surgeons for myomectomy, and for whatever reasons, if they're poor surgical candidates, or they review their MRI and their surgeon said it's going to be an open myomectomy and they don't want that big of a surgery, you know, embolization is a potential option as well.
Can you talk a little bit more, because we did have someone in the questions ask if you could talk a little bit more about embolization. What does that entail? What is the recovery like?
Mm-hmm. Yeah, so embolization is a non-surgical option where, so uterine fibroids are very vascular. So the idea is with uterine artery embolization, we're depositing tiny little particles under X-ray to the feeding vessels to the fibroids. These fibroids suck up the particles, choke off, and die. It's an outpatient procedure through a 2mm incision either in your wrist or in your groin. Same day procedure, takes 1 to 2 hours. Patients go home same day. And patients, you know, especially with bleeding, cramping symptoms, do extremely well. Usually within the first cycle or two, their symptoms are better. And then as for the bulk symptoms like urinary frequency, pelvic pressure, and everything like that, you'll see an improvement over 3 to 6 months after that. But it's, you know, it's another good option for patients who may not want the hysterectomy or bigger myomectomy surgeries. It's a great option because, especially a lot of my patients are women who are working or women with small kids, and you don't have the ability to take that downtime. Most patients after uterine artery embolization are back to normal activity in 5 to 7 days, but the day after, they're up on their feet. Most of the issues or side effects of uterine artery embolization is what we call post-embolization syndrome, where your body's reaction to the fibroids dying, and so patients feel tired, feel sluggish, and so those days after is just getting your energy back.
You know, you touched on something that I think a lot of people don't even consider is a lot of women now are working women. They may have families, and no, you cannot be down and out recovering from surgery for weeks on end. You know, I know for me, I don't have family nearby, and you know, I don't really know with my kid. My husband's there, but he works, and so it would just be extremely difficult. Okay, Tanika's asking, why is the data inconclusive about the UAE and fertility?
So the early studies weren't that great. The FEM trial just came out. New England Journal of Medicine just presented that, comparing myomectomy to uterine artery embolization, where they found myomectomy had a slight better quality of life improvement after 2 years over uterine artery embolization. But I think the grand message is both options, myomectomy and uterine artery embolization, are very good options for patients who don't want hysterectomy. Give a little clue that, you know, both patients both sides did have live births. They couldn't really draw a comparison, and I think they're planning on doing a more larger study to really see what is the effect of pregnancy rates and complications post UFI compared to myomectomy. And I think in the coming, you know, when these studies come out, it'll be a lot more informational. The early study that a lot of some doctors may talk about is, it was a study in 2008 that said, you know, uterine artery embolization is not a great option for pregnancy, but a few years later, Cochrane review said that like I said, the data was weak. So we just need better data. But like I said, you know, end of the day, I still tell my patients, you know, talk to your gyne surgeon, talk about myomectomy first. And, you know, I'm here to talk about embolization. I think it's a great option 1B.
Yeah, and I find just in general, women's health issues aren't really researched. They're not given the funding, they're not given the time that they should be given. So they're always looking for more research and more studies. Misha is asking if you all could talk about scarring from surgery and whether that prevents pregnancy. There, you know, would a 2 centimeter fibroid in the uterine lining really needs surgery? And I think Dr. Phillips, you had touched on that before. It's about the end game.
Yeah. Sorry, just really quick, jumping off what Dr. N was saying, we need more studies in reproductive age women and UAE. So there's 2 issues. There's reproduction, and so pregnancies, how big the babies are, placental issues, that's a whole other thing. And then there's also comparing the UAE to just our traditional myomectomy. So those are really 2 different things that we're talking about. And I think it's going to be a little challenging to do some of those studies because I don't have a lot of reproductive age women opting for UAE until they finish their childbearing. At least that's been sort of the training with GYN, is we prefer that you would do your childbearing and then we add UAEs into the mix in terms of viable options for your. Getting to your question, resecting a 2 centimeter fibroid from the uterus, we approach it through the vagina. There's an instrument that we use to shave it down to match the lining of the wall. That should not cause significant scarring. The uterus, the lining of the uterus actually heals itself very, very well. And it's rare that we would see what's called Asherman syndrome. That's when the lining has been so significantly damaged, often through instrumentation, that it does scar and close up. A procedure like this, I would not expect that type of complication in ordinary standards.
Yeah, I agree. But just to add, it's an easy way to rule out scar tissue because you really kind of can't tell 100%. And definitely, you know, Asherman syndrome typically happens with more trauma, like a DNC, right? Where the cavity is completely obliterated. And usually those women have no periods, which is kind of a sign that something is going on. But after a 2 centimeter fibroid resection, you might have a couple of small bands. So maybe, you know, the periods seem fine and, you know, nothing seems out of the ordinary. So doing like a saline ultrasound, for example, right, just to quickly check the cavity and make sure there's no scar tissue is definitely kind of an easy and very minimally uncomfortable or invasive way of checking, just to be sure.
Dr. Nim, I have two questions for you regarding UAE. The first is, what size fibroids is it typically used for? Is there a limit? Do they have to be small? Can they be larger? And also, a 51-year-old female, no fertility concerns, 2 prior C-sections, doesn't want to undergo another major surgery. So is UAE an option for her?
Right. Yeah. So for UAE, there's no size limit. There's that, sometimes patients may hear that the fibroid may be too large or there are too many fibroids, but in actuality, there's no size limit, and we actually try to kill all the fibroids at once. The one big thing that I try to tease out with my patients is what is their true issue. I always break it down to bleeding and cramping, and then the bulk symptoms as these fibroids get larger with like the urinary frequency, pelvic pressure, distension. If your big issue is the bleeding and cramping, UAE is going to do great. Patients do very well. They get their improvement to normalizing their cycles, decrease menstrual cramping. On the other side with the bulk symptoms, if that's their main concern and you have, let's say like a really large fibroid, on average, after UAE, fibroids will shrink about 40 to 60% in volume at 3 to 6 months. And that's part of the one kind of consideration is, besides the shrinkage, is also the change in density. When fibroids are alive, they're fibrous, they're very hard like a rock. So when after UAE, the fibroids are necrotic, they get soft and spongy. But the patients who have really large fibroids pressing on their stomachs, they have pushing out their bellies and whatnot, they may not be happy with that change in size. And so those patients may be better suited for surgery. But on the flip side, there are plenty of patients I see who just don't want any surgery at all. I think for your second question, we see plenty of patients who've had either myomectomies or C-sections in their case and don't want another surgery. Uterine artery embolization is a good option.
Yeah, I think as Dr. Nem mentioned, expectations it's very important to kind of explain to the patient beforehand what are realistic expectations, right? So if the uterus up to the chest bone, even though there may not be a theoretical size limitation in terms of UFE or UAE, we have to tell her you're not going to see this huge shrinkage, right? It's not going to go from a beach ball to a orange size. So, maybe let's not put you through a procedure that's not very likely to be effective in the sense, again, that your perception or your symptoms are going to change, and maybe a surgery is more appropriate. So, again, it's just managing expectations. And, not every surgery, again, has to be super invasive, right? So there's less invasive options where you kind of kill 2 birds with 1 stone.
So as Tanika will tell you, I am typically bad with time, but I think I'm doing pretty well tonight. So I'm going to go ahead and start wrapping this up. Jae, I just want to say thank you so much for being so candid with your story and so gracious for sharing your story. And I hate that you had to go through such a long and frustrating and exhausting journey to get to an end result. I hope you do reach out to Dr. Phillips regarding your treatment plan and other options. But I want to piggyback off of your situation and ask you and the doctors what your advice would be for people who were on this call listening in terms of advocating for themselves. What are the questions they need to be asking? What are the options they need to be researching on their own? How can we make sure that, I don't pay for a surgery and then I come out of it and you tell me, oh, well, there's still some stuff in there and now I'm mad as hell. So how can we advocate for ourselves from the beginning? And Jae, I'll start with you.
For me, it's just about asking the hard questions, and like you said earlier, really developing a great relationship with your doctor. I've learned that the hard way. And because I'm not originally from Atlanta, and really finding another doctor that was here was very difficult. And then someone you can trust as well, so don't be afraid to ask the questions and find out really what's going on with you. I really wish I had done that early on. I think a lot of things could have been prevented And then two, try to stick with the same OB. You know, I made the mistake by, you know, being here for 7 years. I've gone to 3 different doctors, and mainly because of the area. You know, Atlanta's so spread out, you know, so it's like, you know, now I travel all the way to Gwinnett to see my doctor. So, you know, again, find someone that you truly can build a relationship with, that you can be candid with and grow with them, and you know, just be open about certain things that you're going through. And it's okay to, you know, to feel like, hey, you're at your wit's end. You know, I was embarrassed a lot about talking about it, even on social media. Being an on-air radio personality, I was embarrassed because I didn't know at the time that I wasn't the only person dealing with this. You know, I didn't know that this was normal, that, you know, I could just totally be walking around and blink through my pants. I didn't know. And I wish I had, because once I made the post a few months ago and today, a lot of women reached out in the DM. They did not comment under the post. And so that's a problem. I think we need to be a little bit more, women need to come together, and we need to figure out, especially African-American women, because I think we are affected by fibroids than any other race for the most part. And so we have to be able to build a system. So thank you to the White Dress Project for even creating the conversation and having an amazing platform where women can share their stories. I appreciate you for that. And thank you to all the doctors, the physicians who are on today and asking, you know, answering the questions.
Yeah, I definitely agree with you. I feel like silence will be the death of women because we just don't talk. And I don't know what it is about us, but we just endure to the death of us, to a fault. And it is just, you know, we don't have to. You know, before I let the doctor speak, I'll say, in terms of one way that I advocate for myself, I move around a lot. And Jay, I'm sure you can relate. In the media business, you move around from job to job. I've moved states. I've lived in several different states. But every time I go to the doctor after having fibroids and myomectomy, I say, I know my insurance says, you know, go once every 5 years or something ridiculous. I just know how much changed in a year for me. So I tell my gynecologist, I'll be here every year, do whatever code you need to do so that my insurance covers it, but I'm going to be here every year. And you know, I've had a fibroid come back, so I know my body better now. And you know, Dr. Nim, I hope you touch on the education aspect of it, because I think it's so important. So Dr. D, I see that you're unmuted. So your advice on advocating for yourself as a patient in the doctor's office.
Yeah, I mean, you have to advocate for yourself, because, you know, whether it's a new doctor or someone you've had a relationship with, you have to be your own advocate, because sometimes maybe you're in an area where there are just not as many women with fibroids. Like, I had a patient who lived in Kentucky for a while, and she's an African-American woman, and she said, I just don't think my doctor saw a lot of fibroids my size, you know, and she received really, you know, bad advice for what she had. So really advocating, understanding the fibroids or whatever the disease you may have, understanding what's normal, understanding the effect delay in care or inappropriate care may have on you, right? Because everybody's situation is different. But certainly being your own advocate and realizing that you don't have to put up with something abnormal for many years. There can be a much quicker solution. And if you're not getting it from one place, then you may need to go to 3 or 4 or, you know, 10 different people.
Yeah, I mean, just want to piggyback on Dr. D. I mean, I definitely agree that some patients, you know, if you're not getting the answers you need and things aren't getting better, seek a second, third, fourth opinion, because it can potentially just be delaying your treatment, and things could be getting worse over time.
Dr. Phillips, I'll let you chime in.
Yeah. I had a few things. Absolutely get a second opinion. I have I invite my patients to give second opinions. And I feel like when your doctors are confident about the information that they're imparting on you, as it relates to you specifically, and not some catch bag for how we handle fibroids, you will go back to that doctor because they gave you all your options. They individualized your care. And so I invite my patients to get second opinions all the time. And without fail, they do their research and they come back and we move forward together. I think as a community, in particular, we have to end this cultural silence of what it means to have a period. The fact that we bleed and we're in pain and we don't talk about this stuff really needs to stop with our generation. And so we need to do better about educating our kids. And so when they go into doctor's offices, they feel comfortable, they have language, they know fibroids, they pelvic pain, my periods hurt. They can use these words to communicate. I tell people that they should also get their referrals from friends. If you have had girlfriends who've had a good experience with the doctor, I would use that to help guide my journey as opposed to, and people do Google me, but as opposed to just like picking someone off of an internet search and not really doing your due diligence about the person. I see doctors all the time who have really? So often I think referrals for people who've had successful fibroid surgery are very helpful. And I think that sometimes, unfortunately, when patients come to appointments, they clam up. They clam up and come prepared by writing those questions down. So you can't clam up because you already wrote them down when you were of sound mind, and then you can go through them. Understand that sometimes we can't do everything in one visit, so be prepared to come back for another visit. If you've had recent imaging, bring that imaging with you so we can have conversations. But those are the things. And to Jay's point, and I know it sounds like you've had a horrible financial experience with medicine, but I also find that sometimes patients have insurances that don't necessarily allow them access to the best doctors. And that's a whole other Zoom, TED Talk, all of that. But there are times when you have to like get your coins together so that you can see doctors who are qualified, well experienced, and that you trust. And so sometimes we have to put some skin in the game. So do your research, and sometimes we have to pay a little more for our health care because that's all we have. That's all you have is your health.
Yeah, can I just add one tiny bit to that? I definitely agree with you on that. However, we have to be aware that, you know, some places they'll have doctors that will only charge cash, and they'll, you know, come up with this astronomical number,
price,
you know, and they make the patient feel like they're the best out there and that, you know, they should not even go and find somebody else more affordable because they're just going to be inferior. And I think that's just them taking advantage, you know, of someone who is, you know, very desperate to get good care because they think, you know, it's so important, obviously, to get good surgical care or medical care. And so they give up their last savings. And that's just a whole other big topic.
Yeah, yeah. There are ways, and we can talk about this, Jay, too. That's why I was texting you. There are ways, again, like referrals, to find doctors that will provide you excellent care within the scope of your insurance. And even if they're cash, there are ways to minimize the impact, the financial impact of your health care. There are websites you can go to make sure that what they're charging you is reasonable. So again, I think referrals, first off, with people who share your insurance are important. But like, I live in New York, there's a lot of people who have very, very poor insurance. And if they step up their insurance, for example, from like a bronze to a silver, it opens up a world of doctors for them to get the care that they need, and then they can drop back down to the bronze. It's just really about little tips and tricks. So talk to people about that.
Yeah, that is some great advice. You know, I think a lot of times we're so focused on fixing the physical And so when it seems like you've met a doctor who has this awesome treatment plan, like, oh, I'm going to get fixed, and they drop this bomb of a bill on you, it's like, well, guess I'm not going to get fixed, and I'll just keep on trucking through. So I agree with you, Dr. Phillips. It's all about the research and finding the right doctor who fits your insurance. And then those referrals are key. I've had so many friends still in New Orleans who, hey, Adrianna, I've got this problem. Who did you go see? And I'm right there. Here is her name, her office number, her cell phone. Tell her I sent you. And you've just got to be that advocate for yourself and for your friends and family. So with that, my part is over. Thank you all for joining and listening in. Thank you, doctors, for being here and sharing your expertise for free. It is invaluable. You don't have to send
we do things for free.
Exactly. You don't have to send any codes for our insurance. So that is always wonderful. And Jae, thank you for being so candid and sharing your story. And again, I hope that you and Dr. Phillips connect, and I hope that we have an outcome for you that fits your quality of life and that is satisfactory for what your end game is. So with that, I will turn it over to the founder of the White Dress Project, the one who starts these conversations, who ends the silence, breaks the silence, and gets us all talking, Tanika Gray.
Hi, everyone. Thank you so much, Adrianna. Every time we do these sessions, I'm always so empowered to continue the work that we have started for women. I started this organization because I didn't want to feel by myself anymore. I didn't want to suffer in silence. And even though my mother had fibroids, I still felt like I was alone on this journey. And I didn't understand, if so many women were dealing with this, why we weren't talking about it. So I love that women are participating in this. I love that we can connect with doctors with so much expertise. We call this like your free doctor's appointment without having to take a PTO day. And it is so helpful, and it's so encouraging when we can connect with doctors who are so transparent and are at the top of their field. Jae, you are the ultimate patient advocate, media personality. You're so well-spoken and beautiful. And we just thank you for being so candid about your story. I think sometimes when we look at celebrities and we look at influencers, we think that they can't be going through the same things that we're going through. And I think it's so important as a person of influence to be so candid and share what you are going through as it particularly relates to fibroids. A part of what we do at this organization is make sure that women understand that they no longer have to suffer in silence. They don't have to feel alone. Dr. Phillips, you said that, it's so important for us to end this silence in our generation. And that's what our organization wants to do. Jae, you mentioned that now that my daughter is 14 and I know all about fibroids, I want her to know how to deal with this in her childbearing years. And I think that is so important, like making sure that, like Adrianna said, that we don't hear about this, our mothers don't tell us about this when we're being wheeled into the surgery room, right? That we are having these conversations in our community, amongst our girlfriends, amongst our tribe, and making sure that we are connecting with each other. Dr. Phillips, you also said we have to challenge ourselves to be brave. Dr. D, you said the earlier you address the problem, the better your chances for fertility. And I definitely appreciate you, Dr. M, for talking so transparently about UFE, because a lot of times we feel like we connect with interventional radiologists and they're kind of like, just do UFE, like nothing else is out there. So thank you for your transparency. For every person, I don't want to just say women, but for every person who is on the call tonight, thank you so much for being invested in our organization. We are a nonprofit, so you can donate to our organization. The link is in our bio. It's a text to give, so super easy to support our organization. And if you feel like your question hasn't been answered tonight, there are a group of advisory council doctors that we have that are so open to answer questions. So please send us a DM, jump in our comments, whatever you want to do. We want to keep this conversation going.